Good morning. I'm so happy to have the opportunity today to start off this symposium talking about the basics of MS. For the next half hour, we're going to discuss the basics in 5 different areas. These include what MS is, what are the common presenting symptoms of MS, what are the risk factors as we understand them for MS, how is MS diagnosed, and how is MS classified? So to begin, what is MS? Multiple sclerosis is a chronic disease of the central nervous system. The central nervous system is composed of 2 main parts, the brain and the spinal cord, and then also as an extension of the brain, in the case of MS, the optic nerves. And in MS, the immune system inappropriately attacks the myelin sheath and sometimes the nerve fiber itself, causing inflammation and degeneration. So what does that really mean? Well, the immune system in every person is put in place to guard against infections. And we've all seen the immune system at work on our skin, actually. So if you think about if you have a cut and it gets slightly infected, it quickly gets red and angry. And that red and angry look to the cut, that swollen red look, is coming not just from the infection, but from the inflammation, the white blood cells that have traveled to the area to get rid of the infection and to close the wound. In the case of MS, what we believe is occurring is a case of mistaken identity. And so what happens is the same white blood cells that are there to guard against infection mistake the myelin sheath, the covering around the nerve fiber, for a foreign substance. And they travel to the area and they cause an injury. And you can see there's 3 different nerve fiber diagrams. The first one is a healthy nerve fiber. The second one with the red swollen look is the inflamed nerve sheath. And so this inflammation causes the symptoms of MS that occur over a couple days. You may hear that word a lot in the MS Center, that this is inflammatory activity. There's also a second category of MS. These would be the more chronic, progressive symptoms that are likely caused by degeneration. Instead of the white blood cells traveling to the area and causing that immediate attack on the nerve fiber, this is instead the loss of the nerve fiber over time. And so translated into something that we can see on MRI in a patient, inflammation causes lesions. So it's probably a very common experience in this room that after having a neurologic symptom and going to the neurologist and the MRI is performed, and the neurologist says, "I see a lesion." So what a lesion is exactly is a localized area of the brain or the spinal cord where there are an abnormal amount of white blood cells, that inflammation that we had talked about. It's important to know that most MS lesions are silent. So a very common question to me is, how many lesions do I have? I actually don't count the number of lesions that a patient has. The reason why is, although it's good to know if a patient has a lot versus a little, if a patient has 5 lesions, that doesn't mean that they've had 5 symptoms distinctly from MS, because most lesions occur without the patient ever being aware of it, and then they become inactive and never cause a problem to the patient again. So that's important to know. When a lesion is new, you may have heard the terminology that it lights up with the contrast that's given through the IV. That's a new lesion, what we call an acute lesion. And when that occurs, that's the only kind of lesion that can cause the symptoms that can cause an attack. And so the lesion will light up, usually, you're going to hear more about this, but for a period of 1 to 3 months, and that's a new lesion. So what is an attack? So I told you that most lesions are silent lesions. But if a lesion occurs in an area that is important in terms of neurologic function, then a patient can experience an MS attack. It is true that most of our brain is wasted space, if you've heard that before. But there are parts of the brain, of course, that are very important. And so if one of these lesions occurs in the motor area or the sensory area or an area that causes, that is important for function, then a patient can get symptoms. Other names for attack that you may have heard are relapse or exacerbation. These all mean the same thing. And what an attack is a new neurologic symptom that lasts greater than 24 hours. And then the outset, the long term would be for a month. Don't worry too much about it lasting for a month. What that means is if a patient has 2 new symptoms that are 31 days apart, those are 2 different attacks. Compared to if they were within a month, we call that the same attack with 2 symptoms. But what's really important to know is the 24-hour part. And so if somebody has a new neurologic symptom that lasts for seconds or for minutes or for hours, that is usually not a new MS lesion, a new MS attack. The reason why is because it takes some time for those white blood cells to go into the area like we have discussed. And so it takes longer than a few seconds. So of course that should be discussed with the neurologist because other things can cause neurologic symptoms that last seconds or minutes, but it's probably not a new MS symptom. Usually the onset is gradual in terms of symptoms, so it's not sudden. So it usually, again, it kind of builds up over a couple days. It occurs in the localizable part of the nervous system. So what that means is we have patients a lot that come in and tell us, and of course this can be happening, but that they're very fatigued, that they're off, they just don't feel right. That's not typically an MS attack. Usually when a patient tells us about a new MS attack, they tell me the symptom, and I can guess fairly accurately where in the nervous system it's coming from. This is from the optic nerve, this is from the right side of the brain, this is from the spinal cord. So things that are very vague are usually not an MS attack. And there's no signs pointing to what we call a pseudo-exacerbation. So a pseudo-exacerbation is when leftover symptoms from an old attack come back. And this is very common. The most common time this can occur is in the setting of an infection. So when the temperature rises, the old symptoms come back. And so that is not a new MS attack. But what is important to know is that if you do have new symptoms that last more than 24 hours, please call your doctor to discuss. And so the first category of symptoms is acute inflammatory process that we had talked about. That's the first part of MS. The second part is the progressive part. So what is progression? Progression, instead of occurring over a couple of days or weeks, occurs over the course of months or years. This is the gradual worsening of symptoms. And instead of inflammation causing it, it's degeneration. So that's what we understand right now. And so, as I said, this is the loss of the nerve fibers. Instead of the injury to the nerve fibers, there's a loss of nerve fibers. Current therapies mostly target the inflammatory activity that causes attacks. So future therapies will focus on stopping and repairing degeneration to prevent progression. So what are the common first symptoms of MS? So it's important to know, and we stress in the MS Center, that every patient is different. So if I went around the room, everybody would probably have a story that is unique from everybody else. But there are some common initial symptoms. And those include visual symptoms, either blurry vision in one eye or double vision, sensory symptoms, like numbness and tingling of an arm or leg, weakness, loss of strength in a limb, and then dizziness, and most commonly that would be vertigo. And when a patient comes to an MS doctor, what do we want to know from them in order to help treat them appropriately? And so I'm not a big fan of meticulous journaling. So there are some patients that maybe they find it helps them, but to document kind of hour by hour or day by day what's going on, I think sometimes that people focus too much on the symptoms that way. But I do think that actually this outline is a good idea for patients to at least think about and maybe even write down, especially when they're going to a new doctor. And so what we want to know as an MS doctor is what previous episodes has a patient had. So these would be previous attacks. And what we want to know about them is when they occurred, where they occurred in terms of where in the nervous system, what symptoms did they cause, and how the patient got better from them, how the symptoms resolved. We also want to know about chronic symptoms. Of course, that would be the residual symptoms that I just talked about. And then also symptoms that sometimes patients forget to speak to us about. Those would include bladder, bowel, and sexual symptoms, fatigue, mood symptoms, and problems with cognitive function. And the reason we want to know, other than that we care, is because we can do a lot for these symptoms. So it's not just about preventing future attacks, but it's also about optimizing a patient's life today. And then lastly, and an important piece, is are there progressive symptoms? Are there those symptoms that are getting worse, slowly, little by little? So we talked about what MS is and how MS can affect a patient. So what causes MS? It's my only attempt at a joke in this lecture. It's the million-dollar question. And so currently, we don't know. The cause remains unknown. But it's probably a combination of factors, including genetics, potentially a virus as the trigger. We talked about this case of mistaken identity, perhaps a patient's immune system responding to a virus then causes an autoimmune attack. Environmental exposures, vitamin D deficiency, and smoking. These are all potentially causes that of MS. And so in terms of genetics, this is a bar chart that shows the risk based on the relationship of a person to the MS patient. So overall in the US, the risk for MS is about 1 in 1,000. But then a risk for an identical twin, so that's a twin that has the exact same DNA, is about 25 to 35%. For a fraternal twin, that's a non-identical twin, or a first-degree relative, the risk is between 2 and 5%. So that's a first-degree relative, it's still very low, on average about 3%, but higher than the 1 in 1,000 that it is for any person in the US. And if a person is adopted into a family, they have the risk of the general population. So it's not just living in the same family that causes the risk for MS to increase. It actually is some shared genetic information. Another risk factor is gender. So we know that MS occurs 2 to 3 times more often in women, and this does seem to be an increasing ratio. And also, if the MS patient is a female, then the relative of the patient has a slightly increased risk for getting MS compared to if the MS patient is a male. But that's just a slight increase in risk. Another thing that you may have heard about is the increase in MS in terms of where a person lives, in terms of with the equator. So as a person moves away from the equator, they have an increasing risk for MS. And the highest risks of MS is in the Caucasian populations of Europe and its former colonies, and then lower risks in other populations. But everywhere that we have looked for MS, we have found it. But as you go up in latitude and away from the equator, the risk goes up. And then I'm just going to touch upon this briefly, but in the past few years, there's been some thought that vitamin D deficiency can have some sort of causative role in MS. So there's many studies that have shown that patients with lower vitamin D have a higher risk for MS. And as far as treating MS with vitamin D, we need to do a trial to see if this will help MS. And then smoking. This is one of the topics that I'm passionate about. But we know that now there's been some studies that show that there is a link between smoking and the risk for MS. And studies show that smokers also have a shorter time from the transition between the relapsing form of MS to the progressive form. And so the reason why we think is because smoking is likely, well, we know it is a toxin. It's a neurotoxin. And it may also have immune system effects. And so with this information, if there are any MS patients out there that smoke, I'd like you to stop today. It's very bad for you. And so how do we diagnose MS in a patient? And you have maybe heard of this in the past, dissemination in time and space. There are criteria that were just updated last year. Dr. Lublin was part of the committee that did the updating on the criteria. And what we know about diagnosing MS, so what we know is it's multiple sclerosis. It's not something that happens one time, but it's something that happens more than once in terms of the attacks or the progression. And so dissemination in time, what that really means is that a patient has had a symptom more than once in time. And the MRI can also help us with that. So if you take an MRI and then you take one sometime later and it shows a new lesion, that also means that it's dissemination in time. There's been multiple events. The other way that MS is diagnosed is with dissemination in space. So the symptom cannot happen in the same space over and over. That means it has to be in two different places, for instance, the optic nerve and the spinal cord. That's dissemination in space. Again, the MRI can help us. So if lesions are in different areas, then that's dissemination in space. Always in MS, the caveat is no better explanation for symptoms. And so we know that there's no one test that can diagnose MS. And so if there's something that better explains why the patient is experiencing what they are, then that's a better diagnosis. And this is just going to be very brief, but these are just pictures of MRI. You're going to hear more about this. These are MRIs of the brain in MS. And this is an MRI of the spinal cord in MS. So a very important tool for us these days in order to help diagnosis. In terms of other diagnostic tests, the most common one would be the spinal tap. So this is actually not something that we do very commonly anymore. And it used to be, perhaps before MRI. The main goal of the spinal tap is we're looking for something that is a little bit tough to say, oligoclonal bands. And those are antibodies in the spinal fluid, and we don't know what they're antibodies to. But if that pattern of antibodies is in the spinal fluid, we call that supportive criteria for multiple sclerosis. And that may help us in a situation where it's not exactly clear if MS is what we're dealing with. If a patient has a positive spinal tap, then it leads us towards a diagnosis of MS. There are a lot of urban myths out there about spinal taps, but they are safe and minimally invasive procedures. So if your physician does recommend one, it is a safe procedure to undergo. And then this is not to rule in MS, because I told you there's no one test that can diagnose MS. But sometimes a doctor may order tests to rule out other diseases. Those tests may include tests for Lyme disease, B12 deficiency, rarely syphilis, and some rheumatologic conditions such as lupus or Sjogren's syndrome. Now, what's really important to know in terms of blood tests is that if the patient doesn't have any symptoms pointing to these other conditions, doing the blood test just gives us negative results. So a lot of times, of course, and understandably, when patients come into us, they say, what else can this be? What other tests can you order to make sure this is, not Lyme disease or not another condition? But if the patient doesn't have any other symptoms, these tests are just going to be, they're just going to be negative. And so how is MS classified, and what are the types of MS? So this is a big question, of course, and when patients come to us, that is one of the most common things they say is, what type of multiple sclerosis do I have? And the way that I describe the different types of MS to patients is that it's a continuum. And the example I usually use is the flu. So you can think about the different types of patients that are infected with flu. You can go all the way from a patient who has no symptoms of the flu and is a carrier of the flu, and they never knew they had any infection, all the way to patients that are very affected by the flu. And this is the same thing that occurs in all diseases, really, and in MS. The first type of MS we call RIS, or radiologically isolated syndrome. And what this is like the person who had the flu but never knew they had it. And what happens is the MRI is performed for some unrelated reason, such as a patient falls and bumps their head, or they're in a study for something else, and lo and behold, the MRI shows something that looks just like MS. So what happens, and we see these patients in our office quite frequently, is that they come in and we take a history and we make sure that they didn't have any attacks that they didn't recognize, because that can happen if there are some mild symptoms. Maybe, it's just that the patient thinks, I'm just having an off couple of weeks, and go about their business. So if we can't recognize any attacks, then we think that this is a case of RIS, that the MRI shows the condition, but that other than that, the patient has been unaffected. And what we do in that situation typically is we follow the MRI. If the MRI shows us signs of change over time, we may consider treating the patient for MS. But generally, without any symptoms, we don't treat for this condition, and we watch the patient closely. But every case is different. That's really important, especially in this condition. The second type of MS on that continuum is called CIS, or clinically isolated syndrome. This is when a patient has only one attack of multiple sclerosis. And what we know about this is that if a patient has a typical MS-type attack, but it's only the first one, and their MRI is normal, they have a low chance for developing further symptoms. If instead a patient has an abnormal MRI, an MRI that looks like multiple sclerosis, then they have a high chance for developing further symptoms. And we have many studies now that tell us that if we start treatment in a patient that has had their first attack, then they will do better than if we wait until the second attack. So we don't wait until the second attack, typically these days, to treat. This is always a decision, and every treatment decision is always a decision between you and your doctor. And then we have on the continuum the criteria, the MS that has met the criteria for diagnosis. So we had the RIS, the CIS, and now we'll talk about multiple sclerosis. So there's 4 different categories of multiple sclerosis, and it's important to understand that the way that we decide what type of MS a patient has is by what they tell us. So it's really just made on the MS patient's history. And there's 2 key questions that we ask in order to make the determination of what type of MS they have. So the first question is, has the patient had any attacks? And we talked about what an attack is. And the second question is, has the patient had evidence of progression? And we talked about progression. So the difference between symptoms that come over the course of days and weeks and typically will resolve, and then progression where they come gradually over months and years. And it's the combination of when and where these attacks and progression have occurred that make patients fit into one category or another. And the other important thing to know about the different kinds of MS is that we use these in two ways. The first way that we use these categories is really to put patients into clinical trials that have similar characteristics. So if we take all patients with MS and put them into clinical trials and we get a result, it would be very difficult to know what the result means if the patients all have very different MS presentations. And so that's one of the very important reasons why we need to have patients accurately categorized. It's really for trials. And then the second reason is for an individual patient, it does help the physician think about what treatment course to take. But we're not big on giving people a label of this is what kind of MS you have. It's all MS. But it's important to understand how these categories were developed. And so this is just a graphical representation of the 4 different kinds of MS. And as I said, it's a combination of attacks and progression. So, and what these mean are these rectangular bars represent attacks. And then you see the line that slopes upward, that represents progression. So the bar that's all the way, the upper left-hand chart is relapsing remitting MS. That's the most common kind of MS. And all you see there are the rectangular bars. Those are attacks. So that is an attack-only form of MS. If you see the one next to it, the SPMS, that's secondary progressive MS, you see that that patient started out with attacks and then developed progressive symptoms. So that's the difference. One has progressive symptoms, one doesn't. They both had attacks in the beginning. The third category, the lower left-hand corner, is primary progressive MS. You see there's no rectangular bars, and that's because there's only progression. And then the last category is the rarest of categories. That's progressive relapsing MS. That patient, you see with that slope going up there, started out with progression, but then along the way developed some attacks. This is all MS, and it's just the combination of attacks and progression that give the patient the category that they fall into. And so to summarize, MS is a disease with variable symptoms. We know that of the risk factors, the 2 that we can potentially change are smoking. I hope you got that from my talk. I should stop smoking. And maybe vitamin D. These are things we can modify potentially. That diagnosis is made mainly by history and MRI. That there are multiple classifications of MS that are based really on the patient's history. And that the goal of our healthcare team is to allow for the healthiest and most comfortable life possible for every MS patient. Thank you.